like to start off by telling you about a patient. This is Mr. Johnson. He's a 7-year-old gentleman. He's coming into your emergency department today with shortness of breath. He's very much downplaying his symptoms, says he's totally fine. His daughter was overreacting. And since this is the age of COVID, he didn't have any visitors with him. However, his EKG has some concerning changes. And when you call his daughter, she actually says he was really gasping for air when he was at the store today. Also, he has a history of end-stage renal disease, and he's supposed to be on dialysis 3 times a week, but lately hasn't really wanted to go. So you appropriately diagnose him with hyperkalemia and volume overload and arrange for dialysis in the ED. But he says he's fine. He wants to go home. These kind of cases can be extremely challenging and time-consuming for us in the emergency department and stressful for patients and their care partners as well. So today we're going to talk about 3 key concepts: capacity, self-neglect, executive dysfunction, and actionable steps that we can take from the ED so that the next time you encounter a patient like Mr. Johnson, you'll feel more equipped for this encounter. My name's Katherine Selman. I did a fellowship in geriatric emergency medicine at UNC, and now I'm faculty at Cooper University Hospital. It's no surprise to any of us that we see a lot of older adults in the emergency department. But to put it into a little bit more perspective, adults 65 and older only make up about 16% of the United States population, and yet they make up to 40% of our ED patients. Adults 80 and older are an even smaller proportion of the population, only about 2%, but make up at least 15% of our visits as well. So we see a huge number of these patients every single day and every shift. Not only that, our population is aging, so this population is only going to grow over the next 10 to 20 years. So it's really imperative that we become adept at meeting their needs. 6.6% of older adults are considered frequent users in the ED. Frequent use varies depending on what you read, but is typically somewhere around 4 or more visits in a year. And yet this makes up 38% of ED use for older adults. Frequent older users are more likely to have coronary heart disease, COPD, mental health disorders, dementia, alcohol use, and severe polypharmacy. Obviously, not all frequent ED visits are preventable. We expect that, especially in this population that has higher comorbidity burden and things like COPD, they will have exacerbations and complications, and so we will see them frequently. But when do frequent visits, that older adult who is in and out of your emergency room all the time, when is that representing an inability to manage effectively? At what point does that represent suboptimal care causing exacerbations, and that is really an impaired ability to take care of themselves? This is really going to be the core of our discussion today. So coming back to Mr. Johnson, again, he has hyperkalemia, signs of volume overload, really needs dialysis, but he says he's fine, he wants to go home. He'll get dialysis maybe next week or the week after. Does he have capacity, and how are we assessing this? Capacity is made up of 4 parts. The patient must be able to understand the information relevant to what's going on and use that information to apply it to themselves and appreciate how it relates to their own medical status, their own values, and their own goals. They need to use reason to reach a decision, and they need to communicate their choice clearly and consistently. So not going back and forth depending on who asks or how they ask. I'd like you to think for a minute about what the prevalence of patients lacking capacity might be in these 4 populations that we see all the time. Patients with mild cognitive impairment, just general medicine inpatients, nursing home residents, and healthy controls. In this particular study, nursing home residents had the highest prevalence of incapacity, but I think it's really important to note that we can't make generalizations about any one of these populations. So over half of nursing home residents do have capacity to make decisions, and even healthy controls who have no known diagnosis of cognitive impairment or anything like that lack capacity. We as physicians tend to miss capacity, or patients who lack capacity, about 42% of the time. Although when we make the determination, we're usually correct about it. And we're really good if it's an intoxicated patient who can't stand up straight and they're trying to leave, but we may not routinely think about capacity in other cases. And we may only really start to question it when it's a really complex medical decision, or more importantly, when a patient disagrees with us. Capacity is situational and temporal and influenced by a number of factors. So patients may lack capacity for certain periods of time, such as when they're critically ill or delirious, but not permanently. So we really have to assess capacity in the context of a specific decision. For example, a patient may be able to make a decision about starting a new medication, but may not have the capacity to make a decision about a major surgery. This is important because patients with cognitive impairment are still able to participate in their care. It's just about which decisions we're making. Capacity is separate from competency. Competency is a legal term and determined by a judge, so it really doesn't have much bearing on what we are deciding. We want to optimize capacity wherever we can so that patients can really participate in their care and make decisions when they are able to. And we can do so by treating reversible disorders. Delirium, depression, for example, may confound capacity, but do not permanently incapacitate a person. We want to improve communication where we can, so using hearing aids, maybe moving that patient out of a busy, noisy ED hallway to have a conversation, using a language in which they're fluent, minimizing jargon, shortening the amount of information given, and providing enough time for this conversation. And then finally, reassessing. We want to recognize that the patient that maybe didn't have capacity when you saw them last week may now have capacity in a different context. So coming back to Mr. Johnson, after talking to him a little bit more and talking to his daughter, we determined that he did not have capacity about his dialysis, but fortunately in his case, we were able to really engage his daughter to become his advocate and help make his decisions. So I'd like to turn to another patient. This is Ms. Rodriguez. She's 75, she has multiple medical problems. She comes into the ED pretty frequently, usually with shortness of breath, or she has these leg wounds that are non-healing. She was actually just discharged a week ago, and you're just reading the discharge summary from some information, and it says that she's non-compliant with her medicine, and they wanted her to go to rehab, but she wanted to go home. And it was felt that she had capacity to make that decision. How can we characterize Ms. Rodriguez? Is she just a non-compliant patient? Is she just chronically ill? Is this just normal? In this case, she's showing signs of self-neglect. So the essence of self-neglect is really the inability, refusal, or just failure to provide for one's own basic needs. And this can manifest in a variety of ways. It can be the failure to seek medical care or follow through with medical care, but also things like hoarding, unsafe living conditions, poor physical hygiene. It's considered a form of elder abuse, although we don't traditionally think of it as elder abuse because we tend to perceive that as having a third party involved. The prevalence is up to 29% and is probably underreported and depends on what community you're looking in. But older adults with self-neglect have a 3 times higher use of the ED and a 3 times higher readmission rate. So we're already seeing these patients, we're just probably using the wrong language to describe them. Correspondingly, self-neglect independently predicts increased ED use, and the more severe that self-neglect is, the more likely that they'll be in your ED. There's an increased all-cause mortality for adults who self-neglect, and it's a higher mortality than other forms of elder abuse. And this may be for many reasons. So many of these adults may just not realize the extent of their behaviors and how it affects their health, so they may not encounter the healthcare system until they experience a catastrophe, such as organ failure, stroke, severe metabolic abnormalities, undiagnosed advanced cancer. So like many other vulnerable populations, the ED can be a safety net where we could potentially identify these patients who are already coming very frequently, and we can try to intervene before a more severe scenario occurs. We all know that adult protective services exists, but it's not just because someone is hitting grandma or stealing her money. Self-neglect is the most common referral to adult protective services, so we should really feel empowered to recognize it and report it. So coming back to Ms. Rodriguez, In what ways is she demonstrating self-neglect, and why might this be happening? Yes, ma'am.
Are you taking questions now or at the end?
Oh, now is fine.
Okay, can I ask about self-neglect?
Sure.
Particularly the refusal bucket.
Mm-hmm.
So I think I get lost in what is, personal decision making or preferences versus, something that would rise to the level of concern of self-neglect. And then also, in terms of the failure part,
Mm-hmm.
the concept of structural vulnerability, right?
Absolutely.
That they may not have the structures and supports in place to execute a plan. And so, like, the label of self-neglect feels like I'm labeling the person as opposed to the circumstances. And so I just wanted to get your thoughts on both of those scenarios.
Absolutely. And we're actually going to address both of them a little bit coming on. But the question was more about, labeling the person as self-neglect when it really may be a structural failure, as well as like personal autonomy, essentially. We'll talk about it a little bit more, but you're 100% right. Yeah. So for Ms. Rodriguez, why is this happening? Why is she demonstrating signs of self-neglect? She may have undiagnosed cognitive impairment. She may have undiagnosed hearing or visual impairment, or she may not be able to understand her discharge instructions the way that they're being presented to her. She may also have undiagnosed depression. Depression is associated with increased rates of self-neglect and often presents atypically in older adults. So they have less of the mood symptoms and more somatic symptoms. So we are likely missing this in a lot of older adults. Decision-making capacity is really only half of our consideration here. So the ability to make one's own decisions is part of the conversation, but the second part is executive capacity, which is the ability to put into effect whatever decision you're making, either yourself or by designating it to another individual. So if a patient lacks executive capacity, that's called executive dysfunction, and that describes a patient who may be unable to complete complex tasks. They may have difficulty planning multi-step future actions. They may have difficulty adjusting if their routine is disrupted. And executive dysfunction can occur in patients who otherwise have normal cognition, normal mental status, and otherwise have decision-making capacity. A really simple example of executive capacity that we already do in the ED is if a patient breaks their leg, we try to assess, like, are they going to be able to get in and out of their house on crutches? But we don't assess it as routinely in older adults. But imagine trying to take 7 different medicine and insulin 4 times a day if you have difficulty with complex tasks. So just to frame it another way, if you have executive dysfunction in a person who has comorbidities, self-neglect behaviors can develop because of an inability to manage, whether it's food or finances or medicine, and either directly or indirectly lead to an exacerbation of those comorbidities. And then they're more likely to encounter the healthcare system and more likely to be started on medications to try to control their symptoms and their disease. But as their regimens become more complex, they're more likely to have difficulty managing and executing them. So it can be helpful to frame this question as not only does this patient understand their decision, but also are they able to carry out that decision? And determining this in the ED is not quite as clear-cut. Some things you can do is look for patterns. So has this person repeatedly had issues with becoming hypoglycemic because of insulin errors, or have they repeatedly had issues getting follow-up, things like that. If you have time, also talking to family or a primary doctor can also help give you an insight into how they're functioning. Even if a family member isn't considered like a caregiver or they're not present all the time, they may be able to give you some insight into how is this person functioning? Are they able to do shopping? Are they able to do tasks? So after talking to Ms. Rodriguez a little bit more, it becomes pretty clear that she has a lot of difficulty with her medications, especially being in and out of the hospital all the time. Her medicines always seem to be changing, and so it's really hard for her to keep up. She also doesn't drive anymore, so arranging transport to all her different appointments can be really tricky. So in her case, the decision is made to call Adult Protective Services. But if this is her, say, 10th admission this year, why are we only now recognizing it? One of the challenges is there's not really a standardized pathway at most hospitals to recognize self-neglect and for what to do next for these patients. Another challenge is that it really requires a really comprehensive assessment, which is often beyond our scope in the ED, and even the inpatient teams are not always able to provide this, and even some of the primary doctors do not get enough time to do this as well. So Adult Protective Services, or APS, can be useful in this way in that they can conduct a thorough, comprehensive in-home evaluation. And remember that self-neglect occurs not only in medical domains, but also living conditions. And so although we aren't able to access the patient's home, most of us, they are able to go in and assess that a little bit more in depth. They can also help with some of those more nuanced questions about capacity. If you think a patient has decision-making capacity, but you're not sure about the executive capacity, they're able to provide a little bit more assessment there. So in some ways, they can act almost as our consultant. After an evaluation is made, they'll link a patient to services, medical, residential, social, environmental. And with executive dysfunction, patients may have difficulty following through with some of these plans, but APS can ensure that the services are being utilized and the plans are being followed through. If there is a care partner involved, some APS programs also have respite available, which can decrease caregiver burnout. In more extreme cases, APS is able to seek guardianship for patients, but it's really the minority. I spoke with one APS worker who reported that they had about 2,000 referrals in 1 year, and out of those 2,000, only 37 needed guardianship. So it's really considered a last resort. I'd like to talk about one last patient, Mr. Williams. He's 80 years old. He comes in with a fall. He's seen pretty frequently for falls, but fortunately has not had a major injury just yet. Today, he just wants you to repair his laceration and send him home. The paramedic wants you to know, though, they get called out to his house all the time to help him up, and then he refuses transport. And also, his living room looks straight out of an episode of Hoarders, so they're a little bit worried about him. So how do we balance a patient's autonomy with our concern for their ability to care for themselves? After all, patients are allowed to make poor decisions about their health. You know, smoking, working night shifts, these are all bad things, but we still do them. One method is you can consider it almost like the harm reduction model, where we want to reduce negative consequences as much as possible, while still respecting that we may not eliminate the behavior completely, and that ultimately this person who has capacity, they still have autonomy and they're still allowed to make their own decisions. There also have been studies about whether we can intervene on these adults. So a lot of times these may be the more cantankerous or eccentric older adults that we may think of when we think of self-neglect, if they're refusing care. But actually there was one study that showed they had a nurse go out to a patient's home over the course of 10 months, once a month, and gave them vitamin D supplementation. So a very straightforward, low-risk intervention. And these were all in adults with confirmed self-neglect. And they found that their participation rate was very similar to other vulnerable populations. They had a dropout rate of less than 30%, and over 60% of eligible adults enrolled. So they actually may be more willing to engage with us than we initially perceive. Yes, ma'am.
Well, why would they go out and give the vitamin D? Were they all hypovitamin?
No, they just wanted to find an intervention that they thought was low risk and see if people would accept it. And they did measure vitamin D levels as part of the study, but I don't believe anyone was like, it wasn't.
Basically, it was an excuse for going out there to see how they were doing.
Exactly. Yeah. I can give you the study afterwards if you're interested in reading more about it. So APS is able to reduce self-neglecting behavior and harm by 65% when they're involved, and 77% of older adults with self-neglect reported being satisfied with APS and the kind of services that they were able to provide, and they were likely to recommend it to another adult in need. So again, even though we want to respect a person's autonomy, they may be more willing to receive at least partial interventions than we may perceive. And ultimately, the ED is really a starting point. I don't expect you to create a comprehensive care plan for all of these people, especially if they've had years of this kind of self-neglecting behavior. But again, if we're able to intervene and identify these folks before we reach a more extreme scenario, this can be beneficial for them down the road. Some things we can do from the ED, we want to look for red flags. So like we talked about, really frequent ED visits, frequent admissions, readmissions may be a sign that someone is having difficulty managing. Also, any labels of non-compliant, either with medications or with treatment, if they're not going to dialysis, they're not going to follow-up appointments, that may actually be a sign that this person is just having difficulty managing somehow. And then asking, what does support look like at home? If there is no support at all, even peripherally, like a neighbor checking in on them every once in a while, this person is at increased risk for developing self-neglect. We want to engage our APS and social work teams early. The earlier they know about them, the more they can work to ensure a safe disposition. And if a patient is already involved with APS, reaching out to that person's case manager can help avoid unnecessary admissions, and they can also facilitate some of that follow-up. So if a patient needs repeat labs in a couple days and you're worried that they're not going to do it, their case manager, that's what they're there for. They're there to help with that. Also, finding a way to document that person very clearly in the chart. For any medical directors out there, developing a relationship with your local APS can also help improve communication and feedback between our two groups about what is working and what isn't. And then if you really need something right now, because it's midnight on Thanksgiving and social work isn't there, this is a great website that you can type in your zip code and it gives you local resources for transportation, housing, food, and you can translate it into many different languages and print it out for your patients. I'm not sponsored by them, I'm just a big fan. But this is another immediate resource for you. And then finally, if we're trying to talk to a patient who's feeling resistant to care, a couple things we can do. We want to set a realistic safety threshold. So I hear from trainees all the time, this person's a fall risk, they need to go to a nursing home, because we all know that no one ever falls in a nursing home. But many older adults don't have safety as their number one goal. So while it's a consideration, it can't be the only way that we're making decisions. Instead, we want to elicit their goals and try to frame our interventions in those terms instead. So for many older adults, maintaining functional independence is important. Maybe staying at home is important to this person. So you can say, we want to do X in order to try to keep you at home for longer. And then finally, creating plans for worst case scenarios. So just realistically, what would happen if you broke your hip? What would the plan be if you had a stroke and couldn't speak for yourself? Even just starting this conversation from the ED, especially if there's a family member present, can help with some long-term planning for these families and patients. Ultimately, as our population ages and our ED population ages as well, identifying these frequent older adult uses formally, understanding the reasons behind their visits, and developing networks of support for these older patients is going to be more and more of a priority for EM clinicians and will really help you provide the best care possible for your patients. And love to hear any, questions, discussion.
I have a hard time figuring out when to consult APS because the times that I wanted to consult APS are also the times that I don't think someone is a safe discharge, and so I'm planning on admitting anyways, in which case APS usually tells us, oh, then don't consult us, they're safe right now.
Yeah.
Which is a frustrating thing to hear when you think someone is being neglected by family, abused by family, something along those lines. And the patients that I am thinking about sending home, it feels like consulting APS is also like an admission that maybe they actually should be admitted for those reasons. And so I have a hard time finding that situation where APS is useful.
Yeah, absolutely. And this can vary between, because they're all local and regional. A couple things. If you are able to admit someone that you're worried about them going home, that's a fantastic resource. And communicating clearly with the inpatient team that this is a concern, that you do want APS involved can be helpful. In some places, you can't admit for quote unquote social reasons. And so then adult protective services might be more useful from the ED. Developing that relationship with them from the ED as to when can we call you, when's appropriate, might also help. And then finally, I think it's most helpful if you have a patient that you're worried about, but they don't want to stay for the admission, they don't want to go to the rehab, and they have capacity to make those decisions, but you just think they need a little extra support. APS can provide that support. So it's not necessarily punitive so much as we want to provide you extra support and make sure that you're getting the care that you need. Does that make sense? Answer your question, sort of? Lauren.
I would add in that there are many levels between calling APS and doing nothing. And so
That's
that's
true.
not a dichotomy there. You can also build a relationship with local area agency on aging, which every place in the US has, and say, hey, we need to send a case manager out to this person's house, and I'm really worried about them for these reasons. And then they can escalate it to APS if it's needed to be done. And APS is different county by county. They're differently funded county by county. I know ours in Franklin County, Ohio, just recently went to, we want to see each patient in the hospital and help with discharging them to a safe situation. And, waiting till they mysteriously go home and then we find out they were discharged 3 days ago and it was not a good system. So that may be something that you can change by saying, I'm seeing these patients, how do we best work with you to get them what they have? There are other degrees of things. Maybe a patient's having trouble paying with their finances because of their how much they're going to be guardian. You can talk about payee organizations. And so don't think of it as I never consult APS because they don't do anything. You don't see the back end of what they're doing. And there are other people that also work hand in hand with them that can help them in the ED even more immediately than sometimes APS can. Sometimes you may have one APS worker for an entire county.
Yeah, and I know our county APS right now, we're quite limited for their hours, and you can't make a report after hours. So if you are worried about a patient, you have to make them a little mental note to call tomorrow. So that's one thing that I'm working on, trying to develop a relationship with them and trying to figure out a good process, because obviously we see these patients all the time and on holidays and on weekends, and trying to figure it out. Sorry?
Area Agency on Aging, your taxes fund these organizations. The entire U.S. is broke up onto different area agencies on aging. Mine is Central Ohio, and they have case management services, social work services. Each one differs depending on what your county's funding of the program is, but you will have one.
Sorry.
Can you weigh in on our responsibility towards patients when their other providers are split on whether or not they have capacity? 'Cause I have a couple of frequent flyers in my ED. I really think they do not have capacity. I document that, et cetera. I
Yeah.
admit them. I consult social work. I really think they need placement. They get a bunch of consultants when they're inpatient. Half of them think they have capacity. Half of them don't. They get discharged. I see them a week later.
Yeah.
I have consulted APS and whatnot, but where's my responsibility here? What else can I be doing to help these people?
I think Lauren. No, I think you're already doing the right thing, and I'm laughing just because I feel like you were on my last shift with me when I saw a person that I had admitted because he didn't have capacity and they discharged him. So I think documenting it very clearly. I think if there are conflicts or disagreements, trying to have a more formal assessment. A lot of our discomfort with capacity and a lot of other teams' discomforts is we don't always get formal training in it. So consulting someone that maybe has had formal training, often psychiatry is a service that may or may not be useful, or geriatric.
Geriatric says they don't, and psychiatry says they do.
Right.
Every
Oh.
You have to work with those teams, and one thing that I really had to push for is when you're doing a capacity evaluation at my hospital, I need a documentation of project status. You can do an MMSE, you can do a VOCA, but you have to give me a formal documentation with a score of what their project status is. Because a lot of these patients are really good at confabulation, and they will tell you what they want to hear. And the problem we have a lot is they'll say, oh yeah, I'll go to a SNF.
Oh, yeah.
My ex-wife 3 states away is arranging that for me right now. And I
Yeah.
definitely agree with all your plans. And then they go home and they're found, smoking crack on the streets and passed out in an apartment. So, and I look back and these psychiatrists notice, we had a pleasant conversation and they're agreeable to all my interventions, so I do not think garbage should be needed at this time. And the other thing is getting their outpatient case managers, and that's where if they have a lot of insurance agencies and case managers, these patients who are high utilizers. So these social workers can reach out to Blue Cross Blue Shield or whoever your local insurance agent there and see if they have a case manager through there. They have a case manager through their local area agency on aging or mental health boards. And those people can give very good collateral to your psychiatrist and say, hey, no, they told you this, they lied to you.
Yeah. Well, and I think that itself is a red flag that people are disagreeing so much on this person. Clearly, they're not functioning well if no one can agree on what to do or whether they do or don't have capacity. Like, that's not a good sign anyway. Right.
What is the area agency for aging the agency that we would call through just social services?
Yes. Yeah.
Because they keep just sending them their internet, they can't do any of that.
Yeah, and it varies based on county and funding, unfortunately. But, oh, Tony.
I made a quick recommendation. There's something called findhelp.org.
You're actually who showed me it. You actually were the one who showed me it. So.
But area agency on aging is obviously different in different places. It has different resources. But we all work overnights and weekends, and so it makes sense to know a little bit more about what your community has access to.
Yeah, and
the social workers during the daytime, so that you know for yourself during the nighttime.
And honestly, so Rachel and I work at the same hospital. I've typed in Camden here, and it comes up with a lot more resources than what our social work sometimes has. So it is something, but I mean, ultimately there are a lot of structural factors at play that is not always our control, and that speaks more to, if you're into advocating and policy and things like that, getting more funding for our older adults.
But oftentimes we see these patients in the ED and these social services don't get notified about them. So they want to work with your team and they want to build those relationships.
I just wanted to thank you for the resource on the agency for aging and the Find Help, because I work with a community that's predominantly 80% African American, low income. APS is a weaponized. APS is
Right.
considered a weapon against them.
Yeah.
I think a large majority would be quite offended by culturally non-concordant providers saying, I'm calling APS the same way CPS
Right.
has been weaponized against poor minority communities. And so I really like these alternate suggestions, and I think we have to be aware of the cross-cultural implications or some of the implications of us representing institutions that have systemic racism, systemic inequities born into them, and then using other agencies that may have those same philosophies when we interact with our patients. So I appreciate these alternate resources and the fact that it can be escalated up to APS if these other needs fail.
Right.
So I just wanted to, that's both a comment and even like a question if you all agree.
Yeah.
Check me if I'm wrong, but I just.
No, thank you. I think that's really important. And you had mentioned earlier, do we want to even label these people as self-neglect if really it's a structural failing? And I think that's really part of the larger conversation. And as we move away from things like non-compliant and things like that, I think we're recognizing more and more that it's not just all on the patient. And in these cases, it may be executive dysfunction. It may just be the social networks are really failing. But I think it's part of a larger, more important conversation. And thank you so much.
Some of the more benign topics you can start with is food insecurity and
Yeah.
Meals on Wheels and things like that.
Mhm.
If you talk to them and you're having trouble cooking and stuff like that, you're talking about the abilities of things they're going to do. starting some of that as an open door sometimes will also bridge that this is a specific need I have, and there's a specific organization, probably on your Find Help website, that would allow them to start seeing those types of resources, especially if they don't have a social media.
Yeah, absolutely. Well, thank you all so much.